So when to suspect? If some patient is having swelling that is more than 1 centimeter in the neck, armpit or groin, if in groin more than 2 centimeter, with or without redness, fluctuation or sinus discharge, they may or may not be associated with your fever, weight loss, night sweat or cough. That is very important. They have simply isolated lymphadenitis or lymph node enlargement. They may not be, fever may not be there, weight loss may not be there. That is very important. And there may be history of similar swelling in the past, or there may be the history of tuberculosis treatment. Contact history may be there. Somebody in the family or in the near relative was being treated for tuberculosis in the past and patient has close contact with that. And how to diagnose, how to do a diagnostic workup, how to do a diagnostic confirmation. Again, we do a routine blood work, we do a lymph node sampling, we do a FNSC and send the sample for cytology and CBNet and to look for the classical caseating granuloma in case of lymphadenitis. And the treatment remains 6 months of your standard anti-tubercular treatment, including 2 months of your HRJD, that is in the IP phase, and 4 months of your HRE in the CP phase. The role of steroid, there is no role of steroid. Steroid is not indicated in tubercular lymphadenitis. And the important remark is, some patient when they are on treatment for lymph node TB, they have some residual lymphadenopathy at the end of treatment. So when the treatment duration is near end or is completed, some patient will have a residual lymph node. So you have to look the lymph node size. If it is more than 1 centimeter in size, we divide them into 2 categories. One is called partial responder, where the clinical features have persisted or reappeared. That is very important. So first is called a partial responder and second residual fibrotic lymph node. So what are called partial responder? So in partial responder, if you see, very important, in the partial responder, clinical features have persisted or reappeared. In such patient, additional 3 months of HRE. You have to extend the CP phase for 3 months and then side by side you do a biopsy from the lymph node and look for the histology and send for the TB culture. Also, you do a CBNet testing also in such patient to rule out drug resistant TB cases. And if lymph nodes are residual or fibrotic, that is a normal fate of your TB lymph node, and in such patient ATD need not be extended. So because you have to just do a reassurance to the patient that these are the residual fibrotic node that can persist during treatment. So that is very important to understand. Alright, so this is about TB lymphadenitis. Next, coming to pleural tuberculosis. So in pleural tuberculosis, when to suspect? If the patient is having cough for more than 2 weeks, shortness of breath, chest pain and constitutional symptoms. So in such patient, if you see a classical X-ray here you can see the left-sided pleural effusion. Alright. So in such patient, how to do a diagnostic confirmation? As we do routine blood work, we do a chest X-ray to look for the blunting of your costophrenic angle. That will suggest a pleural effusion. And after that, you do a diagnostic pleural fluid analysis and send the pleural fluid for your routine sampling. And as per your, we do a diagnostic pleural fluid analysis to look for the nature of the pleural fluid and interpret as per your clinical condition. So how to interpret a pleural fluid? There is a separate video for that. If you I will be putting the link for that video. You can go and you can check it out. What are the investigation that should be done in case of pleural effusion? Alright. How to treat such patient? 6 months of standard anti-tubercular treatment is needed. That is 2 months of HRJD, 4 months of your HRE. And the role of steroid? No, there is no role of steroid. And remark, how to do a follow-up? Follow-up X-ray is recommended 2 months after starting treatment to assess the progress. Not before the 2 months, because it will take at least 2 months to see the resolution of your effusion. Coming to pericardial tuberculosis, is very important. Here you can see in the X-ray is a big water bottle heart and the gross cardiomegaly. Here you can see